On April 1st, 2026, a cruise ship left Ushuaia, Argentina, carrying 150 people from 23 countries. 5 days into the voyage, a 70-year-old passenger developed fever, headache, and mild stomach symptoms. He went to the ship's doctor. 1 day later, he couldn't breathe. On April 11th, he died on board. Nobody knew why. His wife disembarked with his body at St. Helena Island off the African coast, traveled to South Africa, and collapsed at the airport before boarding her flight home. She died the next day. Back on the ship, people kept getting sick. April 28th, a German woman fell ill. May 2nd, she died. 3 people dead across 5 weeks. Different nationalities, different ages, different ports, and at no point did anyone understand what was moving through them. I want to walk you through exactly what was happening inside those bodies during those weeks, because that sequence understood correctly is the difference between this disease finding you and this disease never reaching you. A virus from mice can silently destroy your lungs before you even realize something is seriously wrong. It starts like a mask, a normal fever, fatigue, body aches. You think you're fine until suddenly you can't breathe. And the scariest part, you could get it just by breathing in contaminated dust from rodent droppings. This is Hantavirus, and in severe cases, this virus can turn lethal in just hours, especially when one common cleaning mistake sends contaminated particles straight into the air. This virus has been in this country throughout my entire medical career. The first recognized U.S. outbreak was 1993, and what struck medicine at the time was how completely unprepared the clinical framework was for what it was seeing. The initial presentation pointed one direction. The progression went somewhere else entirely. That gap between how this disease announces itself and what it actually does is the central clinical problem. The strains that circulate in the Americas go directly after the lungs, not as a secondary complication as the primary target from the start. When this virus progresses to the point where it affects your breathing, 38% of those patients die. Seasonal flu kills less than 0.1%. We are not in the same category. And what makes that 38% even more significant is the speed. Most serious respiratory illnesses move their mortality across days and weeks, giving medicine multiple windows to intervene. This one can close those windows inside 72 hours of respiratory onset. That 38% only reaches you through one specific pathway. The people this virus finds are not unlucky. They simply never had this conversation. Hantavirus lives in rodents in the United States, primarily the deer mouse found across virtually every region of the country. And the thing I find most clinically significant about this carrier relationship is that those mice show no signs of illness whatsoever. They look normal. They behave normally. They carry this virus their entire lives without consequence, which means there is no visible warning in the environment. No sick animals, no obvious contamination, just a space that's been used and a biological residue you cannot see. What infected? Mice shed constantly through urine. Droppings, saliva, dries within hours on any surface and becomes dust. Microscopic particles that suspend in the air of any enclosed space where rodents have been active. The moment you breathe that air, the virus enters your respiratory tract directly. That is the primary route, not surface contact, not a bite. Breathing. What strikes me every time I go through Hantavirus case histories is how completely unremarkable the exposure moment is in almost every documented case. Opening a shed door, moving a box that hasn't been touched. Since fall, sweeping a corner. The person is doing something they've done dozens of times before in a space they trust. They act without knowing what's suspended in the air the second they disturb it. That consistency is not incidental. It is the defining feature of how this infection reaches people. One breath in an ordinary place before anything has registered as wrong. Exactly one Hantavirus strain has documented human-to-human transmission. 1. Every strain circulating inside the United States has 0 documented evidence of person-to-person spread across 30 years of national surveillance. If you are in the United States, you cannot catch this from another person. That is not a preliminary finding. That is 3 decades of data without a single exception. But the technically accurate answer that omits the full picture can be more dangerous than no reassurance at all. One strain can spread between people. It requires sustained close contact over multiple days, not brief, shared airspace, not a casual interaction, but the kind of extended exposure that happens when someone is living with and caring for an infected person at close range. That is a fundamentally different risk profile from anything driving current public concern. The couple who first carried this virus onto that cruise ship had been exposed at a rodent contaminated landfill during a birdwatching tour. They boarded the ship almost immediately afterward. If they had waited 48 more hours before boarding, the transmission window would have already closed. That is the margin this virus operates on. Your risk is not other people. It is entirely the contaminated environment, the enclosed space, the air you disturb. By the time this virus is inside you, it has already begun moving through a sequence specifically designed to look like nothing is wrong. The first thing this virus does is make you think you're going to be fine. Fever, deep muscle, aches, the thighs, the hips, the lower back, the shoulders, a fatigue that sits heavier than usual, about half develop. Gastrointestinal symptoms, nausea, vomiting, stomach cramping, which regularly gets misdiagnosed as a GI illness in the first clinical encounter. I've seen that misdiagnosis happen to physicians who knew the patient well and had no reason to look further. Nothing about that presentation triggers alarm. It looks like flu season. It is designed to look like flu season. Then around days 4 through 6, patients feel better. And this is the feature of this disease I find most clinically dangerous, more dangerous than the mechanism itself. Patients feel better, not slightly better, genuinely better. The fever softens, the aches ease. The subjective sense that the corner has been turned is real. It is not imagined, not a misreading. The improvement is physiologically authentic, which is precisely what makes it so lethal. In clinical medicine, I call this the false corner. The patient believes they have turned a corner. They haven't. What they have done is enter the most dangerous window in the entire disease course. Without knowing the window has opened, the virus has already moved. The immune response is already mobilizing at the capillary level. What the patient is feeling is not recovery. It is the body quietly reassigning resources to a crisis. It hasn't announced yet, and because nothing in the symptom picture at that moment signals danger, the window, the one window that matters, starts closing without anyone in the room knowing it has opened. Then the breathing changes, a tightness slightly, short of breath, doing something ordinary, a dry cough. That first change is not a symptom to monitor. It is a signal to act on immediately. Hantavirus pulmonary syndrome. That is the clinical name for what follows. The name doesn't capture it. Oxygen, saturation dropping, blood pressure falling, breathing rate climbing as the body tries to compensate for both simultaneously. When those three measurements move together, that is a medical emergency, not a development to monitor. When oxygen and blood pressure drop together, the body has moved from managing an infection to managing the consequences of one. Two fundamentally different clinical situations, two fundamentally different intervention timelines. By the time all three numbers are moving, you are already in the second situation. And the second situation has a treatment window that shrinks with every hour. Most people miss this turning point entirely because it doesn't announce itself. The early respiratory symptoms feel like a bad flu day, easy to rationalize. By the time it feels severe enough to act on, the margin has often already narrowed significantly. The false corner is what consumed that margin. The apparent improvement bought the virus the time it needed. By the time breathing changes, the cellular damage is already in motion, and the mechanism behind it is unlike anything in ordinary respiratory illness. There is no antiviral for Hantavirus, not because medicine hasn't looked, because by the time you're sick enough to know you need one, the biology has already moved past the point where it would help. The virus targets endothelial cells, the cells lining the inner walls of your blood vessels, specifically the capillaries threaded through your lung tissue. That is where it enters and replicates. When the immune system detects the infection inside those cells, and launches its response. The resulting inflammation causes those capillary walls to lose their structural integrity. They become permeable. Fluid from inside your bloodstream starts crossing through those damaged walls. Fluid moves into the lung tissue itself, into the alveoli, the microscopic air sacs where every breath transfers oxygen into your blood. As those sacs fill with fluid, that oxygen transfer becomes progressively less efficient. Here is the clinical reality that took medicine time to fully absorb. The damage occurring during capillary leak is not primarily being driven by the virus. It is being driven by your own immune system's response to the virus. The trigger and the reaction have separated. By the time symptoms appear, the inflammatory cascade is already self-sustaining, running on its own momentum, independent of what started it. A perfect antiviral deployed at symptom onset would clear the virus, but it would not stop the lungs from filling. The cause and the consequence are no longer the same process. That is why the entire clinical strategy is supportive care, not a compromise, not medicine falling short. The biology of this specific pathogen leaves no other door open. What keeps people alive is managing the immune response and its consequences. Mechanical ventilation, hemodynamic support, ECMO, not targeting the virus itself. Your lungs are still present, still moving. You are still pulling air in, but the surface where that air becomes oxygen for your blood has been compromised. It is quieter than people expect. That quietness is exactly what makes it so dangerous. You are breathing. Your chest is moving. You can feel yourself pulling air in with every breath, but the oxygen is not landing. Your body registers that deficit before your conscious mind does. Heart rate climbs. The hands feel slightly cool, slightly numb as circulation begins, prioritizing core organs. Disorientation that sits just below. Dizziness. The world slightly behind where it should be. Thoughts arriving a half-second late. What I find most significant about this phase is how completely unconvincing the clinical picture looks from the outside. Patient in early respiratory decline from hantavirus can still be having a coherent conversation, still moving around, still telling you they feel okay, and meaning it, not performing wellness. Genuinely reporting their subjective experience. Their oxygen saturation is telling an entirely different story. That gap between experience and physiology is wider and more convincing in Hantavirus than almost anywhere else. It does not create uncertainty. It creates false certainty, and false certainty in this specific disease is what delays the intervention that determines whether someone survives. Then it accelerates. Fluid continues, building in the lungs. Blood pressure drops as volume leaks out of the vascular system, two fronts failing. Simultaneously, oxygen and circulation. That combination drives severe cases into shock. The body cannot walk back from that without intervention. From the first moment breathing symptoms begin, severe cases can reach life-threatening respiratory failure and cardiovascular shock in 24 to 48 hours, 1 to 2 days, not a week. The research does not give us a reliable early marker that tells a physician which patients will deteriorate rapidly versus which will have a longer window. I want to be direct about that uncertainty because it is not an academic gap. It is a clinical problem with a specific consequence. When you cannot identify in advance which trajectory a patient is on and the fast trajectory closes its window inside 48 hours, the only rational clinical posture is to treat every suspected case as the fast-moving one. The cost of that posture applied to a case that turns out mild is a hospital evaluation. The cost of the alternative applied to a case that turns out rapid is not recoverable. Those are not equivalent risks, and they should not be treated as though they are. Patients who reach intensive care before the crisis peaks with ECMO deployed early have survival rates of approximately 80%. That number drops with every hour between when respiratory symptoms begin and when that intervention starts. I have seen what the difference between early and late presentation looks like across the outcomes. The 80% is not a number to hold abstractly. It is a number with a clock attached to it. If you have had a credible rodent exposure in the 1 to 8 weeks before symptoms appear, a closed cabin, a dusty shed, a garage, with rodent activity, and you develop fever with muscle aches in that window. Immediate medical evaluation. Not tomorrow, not after seeing if the fever breaks. Today, the majority of Hantavirus infections in the United States happen during completely ordinary activities. The most common one you see rodent droppings. You recognize correctly that they need to be dealt with. You sweep them or vacuum them or disturb the surrounding dust in any way that moves it from a surface into the air at breathing height. That single act launches contaminated material that was sitting inertly on a floor directly into the air at the exact height where you breathe. The decision to clean was correct. The method was the problem. The people who make this mistake are not careless people. They're doing exactly what they identified needed to be done. The error is not failing to recognize a hazard. The error is not knowing the specific protocol that makes addressing that hazard safe. The people who get infected this way are capable, responsible people. They simply weren't told the right way to do it. The second mistake, you feel feverish, achy, tired. You tell yourself flu season. You don't connect it to the afternoon 3 weeks ago in the storage shed because the incubation period is 1 to 8 weeks, and the cause and the symptom are separated by so much time that the link is invisible. That invisible link is what causes the delay in care that changes outcomes. The third mistake, a surgical mask, a cloth mask, any standard face covering, none of these filter particles. At the size Hantavirus travels, the only protection that works is an N95 respirator with a proper face seal. That specific distinction has cost people their lives. 3 mistakes. Hantavirus doesn't circulate in cities. It lives where human activity intersects with rodent habitat in specific predictable places at specific predictable times of year. Enclosed structures on rural or semi-rural properties that have been closed for months. A vacation cabin, opened for the first time in spring. A storage shed or barn, a garage sealed through winter while rodents moved freely through the wall cavities. For anyone over 60, the risk scenario is the spring and early summer cleanup, opening properties closed since fall clearing. Storage, garages, attics, outbuildings, often alone in familiar spaces that have never caused a problem before. That familiarity is, in my experience, the single most underappreciated risk factor in this disease. The people who tend to get infected are the most capable people. They are self-sufficient people, the ones who have maintained their own properties for decades, who have handled rodent issues before without incident, who have done this particular task many times without consequence. That history of competence without consequence creates a blind spot. Nothing serious happened the last 50 times, so the brain doesn't classify this time as different. That is not carelessness. That is how human risk assessment works, and it is exactly the gap this virus moves through. The highest U.S. case concentrations sit in the 4 states: California, Washington, Oregon, and Texas. But H virus carrying rodents are distributed across nearly the entire continental United States. Right now, I want you to think about one specific space in your life. A cabin, a garage, a shed, a basement, somewhere that has been closed since last fall that you haven't fully been inside. Drop one word in the comments. Just the space. Cabin, garage, shed, attic. I want to see how many people watching this are sitting closer to this risk than they realize. There is nothing waiting at the hospital that can specifically target what's already happening inside you. No drug, no antiviral, no FDA-approved antiviral treatment for Hantavirus exists. This is not a gap in pharmaceutical attention. Ribovirin, an antiviral that shows efficacy against related hemorrhagic fever viruses, was specifically studied for Hantavirus. The results weren't sufficient to support approval. By the time a patient presents with symptoms, the virus has already completed its replication cycle. It has already reached the endothelial cells in the lung capillaries. The inflammatory process driving the respiratory crisis is already in motion before the patient feels sick enough to seek care. The window where antiviral intervention could meaningfully interrupt viral replication has already closed. What kills patients isn't the Virus destroying tissue directly. It's the immune response the virus triggers. Clearing the virus at symptom onset, even if that were possible, would not stop the lungs from filling. The inflammatory cascade is already running, independently of the trigger. The cause and the consequence are now two separate processes. This is not something a better drug solves. It is a structural feature of when and how this pathogen reveals itself inside the human body. Before you enter any enclosed space with potential rodent activity, open every door and window and step back. 30 minutes of ventilation before you go. Inside, not after. Before your first breath inside, that sequence matters. Before you touch or disturb any rodent, droppings, nesting material, or contaminated debris, saturate it first. 1 part household bleach to 9 parts water or any EPA registered disinfectant. Wet the material completely before it moves. Wet particles don't become airborne. That one step is the entire physical difference between a cleanup and an inhalation event. Never dry sweep rodent droppings. Never vacuum them. Damp paper towels, damp mopping sealed. Plastic bags, double bagged before it leaves the space. The broom is the single most dangerous tool. Never bring a broom into a rodent contaminated space. Use an N95 respirator with a proper face seal and rubber or latex. Gloves. Don't touch your face until gloves are off and hands are washed. Put the equipment on before you open the door, not after you've gone inside and assessed whether the space looks contaminated. By the time you've decided it looks contaminated, you've been breathing that air for a minute. Equipment on before entry, not after. Concern arises. Seal any gap larger than A4 in around pipes, vents, and foundation entries. Store all food in sealed, hard-sided containers. Remove brush piles and wood stacks stored directly against your building exterior. Rodent